Doctors Without Borders is an independent medical humanitarian organization. We are a global network of principled professionals working in teams in over 70 countries around the world. And for over 50 years, we've been providing free, life-saving care to people affected by conflict, epidemics, disasters, and exclusion from healthcare. We provide this care to everyone, regardless of race, religion, or political affiliations. Nearly 90% of our funding comes from private donors, enabling us to operate with an unrivaled level of independence. We do not accept funds from governments or companies whose activities are in conflict with our work. Because of this, we can respond to crises immediately and make operational decisions based solely on the critical medical needs we witness on the ground. We offer impartial medical care and remain neutral in all contexts, not taking sides in armed conflicts nor supporting the agendas of warring parties. These are the principles that guide us and allow us access to people who might otherwise be cut off from essential care. MSF is set up to respond quickly and efficiently to emergencies. Over the years, our logistical teams have developed ready-made kits to help us act quickly. These kits contain the items needed to fight a cholera outbreak or get a surgical program up and running within days. They can even contain a fully functioning inflatable operating theater. When medical assistance alone is not enough, we may also supply shelter, water, and sanitation, food, or other services. Thousands of logisticians make sure that our interventions run smoothly. From maintaining the cold chain during vaccination campaigns, to servicing vehicles, from drilling boreholes, to setting up a field hospital, logistics is what makes our medical work possible. Our teams on the ground bear witness and speak out about what they see in order to raise awareness and provoke change.
Thank you very much, ladies and gentlemen. Welcome to this webinar about telemedicine and how this works in MSF. If you can hear me from wherever you are, please just give me a thumbs up. Give me a sign. Yes, thank you. Thank you. I see a few. Thank you. Thank you very much. Now I'm happy. It is good to know that you can hear me. I also believe you can see me. Again, this is a webinar organized by Médecins Sans Frontières, also known as Doctors Without Borders. And we are going to be looking at the whole issue around telemedicine. But even before we get into that, if I could ask everyone who is on call to take a minute and just let us know who you are and where you are tuning in from and what you do on the chat box. So feel free to just put there your name and what you do, and if you like, where you are joining us from. In the next 50 or so minutes, we are going to indulge and talk about this whole thing about telemedicine. And earlier on, I was just looking at some data, and I saw that according to the World Health Organization, the ratio of doctor to patient is about 2.5, or say 3 medical personnel that are able to attend to about 1,000 people. That is what the WHO is asking for. But we all know, probably from our backgrounds or from where we work, that this is not the case. And we are going to delve into this and just find out exactly what is the situation in the different places. Although the World Health Organization calls every medical staff that falls under this category, physicians, nurses, and those who do the work of midwifery. So many communities continue to face barriers to accessing quality health care due to a number of reasons. For instance, geographical, distance, shortage of healthcare professionals, like we have said, financial constraints, and inadequate, health infrastructure. And this is the reality that we live with. So the purpose of this webinar today, we want to try and unpack or explain how MSF, telemedicine, connects field teams to medical personnel. So field teams who are in very remote places to medical personnel who are not within the places where they are, but different places, and just see what is the impact of this whole issue about telemedicine. You want to see how this type of technology can help, overcome the challenges that we have, that I have spoken about earlier on. And the questions around this, how effective, how it works. Probably we'll hear some examples of how, this has worked in different places. We have people who are on this call who are going to help us unpack this whole thing. And if you have a question, you can feel free whenever it comes up to put it on the chat. And we have a whole team from Doctors Without Borders who are with us on this call, the technical team. And we also have experts who are going to help us unpack. So in the course of this discussion, if you have any question that comes up, please feel free. But at the end, we'll have some time for anyone with a question to voice, for those that will not have been able to put them on the chat. Very well, my name is John Riaga. I will be your host for the next few minutes, and we hope to finish at the top of the hour. And so to help us unpack this whole issue about telemedicine, which is medicine and technology, or technology and medicine, we have on the call this morning, Daniel Mgongo. Daniel Mgongo is our telemedicine regional implementation officer covering Central Africa. Daniel, you want to just say hi as you test your microphone before we come back to you?
Hi, everyone. As John said, my name is Daniel. I'm the Regional Implementation Officer for Central Africa, and welcome everybody, and hoping to have a very good session with all of you. Thanks.
Thank you very much, Daniel, and thank you for being on this call. We appreciate you, and we look forward to hearing insights from you. Next is Ivy Wandia. Ivy is our telemedicine regional implementation officer, and she is in charge of Asia and East Africa. Ivy, test your mic with a greeting.
Hello, everyone, and thank you, John, for having us here. I'm really looking forward to the conversation today. Yeah.
Thank you very much. So we move straight into the discussion, and I probably start with you, Ivy. When we speak about telemedicine, the idea, like I have said, is probably technology and medicine, or is it tele for telephone and medicine? What exactly are we speaking about from the horse's mouth?
Okay. So telemedicine is, I would say telemedicine, there are two ways to look at it, but for this session, we're going to look at it, how MSF, we interpret or how the program is run. But telemedicine is basically part of the digital health services offered worldwide. And I think since COVID time, the term telemedicine has sort of become a bit more popular than it was before. But when we come to MSF, how do we look at telemedicine? So it is a program that is run by MSF Canada, but it wasn't always like that. It actually developed as part of a pilot project run by one of our MSF entities, MSF France. And then from then on, the idea was that we were trying to fill in the gap, as you said. In your remarks before, you've mentioned how there's a shortage between the number of doctors and patients, and so there's a clear gap there. And so when telemedicine came about, the idea was to try and fill in that gap. And so it began as a pilot project, which then grew exponentially, and now we actually now hosted by MSF Canada since 2016. So it's 10 years of us being with MSF Canada, and we work intersectionally across all the MSF projects, wherever worldwide. So I am for Asia and East Africa, the officer for Asia and East Africa. Daniel is for Central Africa. We have others who are in different parts, so LATAM, that is Latin America, Middle East and North Africa, etc. So the idea for the telemedicine program is to provide secure solutions, and we do this through the services that we offer. And these secure solutions are designed to support the healthcare professionals in these projects. As MSF, we work in communities that are underserved or marginalized, or that don't have that direct access to healthcare. And so that's where that's where the telemedicine program comes in. So we try and assist the healthcare professionals, whether they're doctors, nurses, CEOs, you name it. We come in and try and provide them these secure solutions, whether it's through the specialists you're going to connect them with, the services you offer, etc. Yeah. So that's what the program is in a nutshell. Yeah.
Thank you very much. That was very comprehensive. One thing I gather is was MSF already, as we know, works in not very, how do I put it, in places that are served with quality, adequate medical services. So that already is is a difficult position to operate in. Maybe Daniel. The services that MSF offers is to provide medical care to people, in different people whose equilibrium has been interfered with in different ways. And that already, is a problem. So how does telemedicine complement the care that medical staff who work for MSF or in those facilities we work, how does this complement the normal care that is given?
Thank you very much, John. So basically, telemedicine is an additional support to the healthcare team. So telemedicine does not replace the care that is provided directly to the patients in the field. Okay. So most in the MSF projects, they work in very remote areas, or rather we work in very remote areas where it is very difficult to have specialists physically available. So telemedicine complements care, where now the teams on the field can always go on the platform and they can always post a case and they can be able to reach a specialist of their choice, for example. So I can give an example. For example, in the field, they can have complicated medical cases, surgical, pediatric, or dermatology cases. So the team can ask a specialist for advice through the telemedicine platform, okay? So what happens is the team will gather all the information, all the medical information, that is the medical reports, the laboratory results, imaging, radiology, if they can be able to have even CT scans, but usually that is very rare. So the team will create a case on the platform and it will be submitted on the platform. Now we have a team of clinical case coordinators who will go through the case and they can be able now to assign the case to the specialist as there it is required on the platform. So basically, if it's a dermatology case, there's a part where the projects will fill and they will say this case is, they require a dermatologist to review the case. So the clinical case coordinators will look at the case and they will assign the case directly to the specialist of their choice. Okay. So overall, what I can say, telemedicine complements care by bringing the specialist knowledge closer to the field to support better clinical decision making and strengthening the teams and creating opportunities for continuous learning. So basically, that's it. Yeah.
Thank you. So it's a complementary service to strengthen the teams on the ground, and as you rightly say, make services even better. So even as we, can we now probably get deeper, Ivy, if you may, and just let us know, the services that that MSF has under the telemedicine scope.
Yes. So all the services we offer are designed, like what Daniel has said. The idea is to basically empower the users in the field, so the medical teams or the clinical teams in the field, and also help reduce the isolation that is there, as well as building a community of knowledge. So when we were the services that you have in the telemedicine program, we've ensured they all sort of do the whole roadmap back to those 3 key points or the outcomes. The first service we have is the case management service, which is what Daniel has explained before. So the project user, the project staff will have access to their account, and they will post cases where they're connected to a specialist. Within the specialist network I'm talking about, some people may be wondering, we have 2 categories. So we have one that is the HQ advisors or the medical reference who are part of the MSF network. And then we also have the volunteer specialists, but all of them combined, we have over 500 registered specialists within our telemedicine network. And so we take them through the whole process. So that's one of the services we offer. The second service is the secure messaging, which is hosted on an application called Cello. And this one comes in because it is an instant messaging application whereby again, it's still for the medical staff for sharing information or patient files or things like that. And so instead of people using WhatsApp, which is what majority of the people in the field have been using, and WhatsApp is not mandated, but not just by MSF, but also medical societies, it's not an application to share anything related to patients. So Cello came in to fill in that gap. And so that's what we also are providing that kind of a service to the projects. The other one is what we call video case discussions. Previously, if there's anybody in the chat who knows, it was previously called clinical case discussions. And this one is an add-on service to the case management service that we offer. So for this one, the project is matched, unlike the case management one, where when a project posts a case, it goes to the wider telemedicine network. For video case discussions, the project is matched to one particular specialist. So for example, in Kenya, we have one. You have a project that has VCD, which is called Mathare. It's by MSF France. And their video case discussions are on mental health. And so every 2 weeks or so, they will meet with a specialist who is matched to that project, and we will discuss the cases that maybe they want to learn more about, or the cases that are a bit more complex or things like that. And so by that, we are still bringing the specialist very close to them and also providing that quality patient care through such kind of learnings. Yeah. So we have 3 in total, 3 services. And yeah.
Thank you, Ivy. So in your description, even with the 3 main services, I don't know if it has come out clear, because one may ask, at what point is the patient getting engaged through these 3 services, because like it's rightly said, this allows, medical staff on the ground and medical staff who are not on the ground to engage in case management and all this. But at what point is the patient, getting these services or getting involved in this service provision?
So the services we provide are mostly provider to provider, meaning that we are dealing between specialists and the doctors. And so the patient gets the benefits from these services from what the doctor gets the advice from the specialist from. So we do not directly deal with patients because, again, the doctors are the ones on the ground, and ours is just to empower them and, again, provide that complementary support that they have. Mm-hmm. Yeah. Mm-hmm. So, however, in terms of the types of cases maybe that have benefited from the telemedicine support, we have a lot of them. And because of the way the program is set up and also the number of specialists we have, so far, I can just giving rough numbers, like last year, we had over 5,000 cases that were submitted. And since 2021, we've had over 26,000 cases that have gone through the telemedicine platform, and 75% of those cases have received a positive response, or at least we've received feedback from the project that they had a positive response. And across the types of like the specialties that we see or the case distribution, the top 3 I would say are probably radiology. We have a lot of radiology cases coming through, a lot of pediatric cases coming through. Again, this is on the mirror of the kind of projects that MSF has. And so even in the field, you'll see a lot of these kind of projects. Also, we have OBGYN cases and also internal medicine. Those are sort of the top specialties or the top patients that we've seen in MSF projects. So through all this, we're able to, and also there's a rise of mental health, and especially for video case discussions, there's a lot of mental health. I think also because of the MSF, and I'm sure also your team, John, is also to be given benefit for this because of, the advancement of mental health. People are talking about mental health a lot more. So we're also seeing that translating back into the number of cases that we're seeing on the platform. Yeah.
Thank you. Thank you very much, Ivy. If you are just joining us, ladies and gentlemen, this is Doctors Without Borders, also known as Médecins Sans Frontières or MSF. And this morning, we are speaking about telemedicine, the work that we do in the places where we work, where we respond as a humanitarian organization, this technology about telemedicine. And that is what we are unpackaging today. If you have not had an opportunity to place in the chat an introduction, just your name, what you do probably, and where you're joining us from, please go ahead. And also, if you have a question, feel free to put it on the chat. We have a technical team that is on that beat, and they will quickly pull your question, and our panelists, Ivy and Daniel, will be available here to answer. Before I come to you, Daniel, just one follow-up question, Ivy. On the uptake, the several places where MSF works with telemedicine, what is the general reaction if you know about the population? Are we still in the age where somebody says, I must see Dr. So-and-so, or I must see a doctor physically, or maybe they don't even know that that there is this technology that is being used? Do they have that knowledge, and what is the acceptance?
Yes, so I do think they know. However, again, remember we are dealing with provider to provider, meaning we are not going towards the patient. But in all the services that we have, we always say that the patient consent is key, which means that the doctors, the doctors that is seeing the patient also has to get the consent from the patient. And of course, I know in some areas it's a bit difficult for them to understand what telemedicine is. And so I assume they phrase it as, them seeking advice from somebody still within the MSF network. So in that case, yes. And just going by the number of cases, because throughout the years it has risen, so I would say the acceptance is pretty great. And also from what we are seeing from even internally with discussions from different MSF entities, telemedicine is continuing to be advanced in that level, and we're receiving a lot more support now. So I'd say that acceptance is now actually improving. Yes. Good
to note. Daniel, this is technology, and I'm sure it comes with its own fair share of challenges. If you could share, some of these challenges that exist that our teams, find as they interact with this system.
We face several challenges, especially working, as we all know, MSF projects, they are in very remote areas. So one of the biggest challenges that we face on a day-to-day basis is internet connectivity. So in some locations, the connection can be very slow or very unreliable. So this makes it very difficult for medical staff in the projects to post cases, like uploading files, just trying to create the case becomes a very difficult task for most of the projects. Another thing is when we're having, like as Ivy said, one of the services, which is the video case discussions, it becomes very difficult to have a one-on-one discussion with the specialist. So because of the internet connectivity, so this sometimes it's very hard for the teams and the specialists to have this conversation. Another thing I can say is the workload. As we all know, the MSF projects, they usually, like right now, we can talk about Congo, where they're facing Ebola. And for example, at this point, time and point, you will find if they have a difficult case, because of the workload, they will not be able to create the case and post and put all the information that is necessary so that the specialist can be able to review. So this, we see, it becomes also like a barrier or a challenge for the specialist to give the proper advice. Another thing I can say is the language and communication. It can also be a challenge, particularly when the field team and the specialist do not speak the same language. So being clear and precise is also very important at this stage. And the last I can say is awareness and training. Even when having telemedicine is available is not enough. So we need to make it, we need to make the staff or the projects aware that we have telemedicine. It is there for them to use. It's for their own benefit, so that we can be able to have, or rather they can be able to make good clinical decision making for the patients on the ground. So basically I can say it's internet connectivity, the workload, language barrier, the quality of information they are posting on the platform. Sometimes because of the workload, as I've said, in Congo right now, they are overwhelmed with the Ebola situation or other crisis at the moment. So it becomes very difficult for the teams to post the cases and give proper information. Yeah.
Thank you very much for that, Daniel. And in a short while, I will ask Ivy to, because clearly these are challenges that evolve. I'm sure there's a point where we started, and as we continue, we make things better as new challenges come in. Ivy, in a short while, I would want you to speak to us about this evolution. But before then, Daniel, looking at the three main services, case management, secure messaging, and even VCD, maybe in a few words, if you could give us an end-to-end, of what happens when a patient walks into a facility and we have telemedicine in place until that point the patient leaves the facility either with medicine or healed or with some kind of appointment or referral, briefly end to end.
Okay. So as Ivy said, we have the three services. So when a patient walks in, the doctor on the ground or in the projects will review the patient. And then he will see, for example, there are cases that are very complex and we do not have all the available resources to treat the patients on the ground. So now this is where now the doctor and the team will start with the case management. Case management, this is where now you will find the doctor. He will review the case and he'll be like not sure of what, or rather will not be sure on the treatment to give the patient. So he'll be like seeking a second opinion. So this is where we go to the case management platform. The doctor will create a case on the platform. He will post all the laboratory results, the medical reports, the history of the patients, and even pictures if when needed. For example, this is in the dermatology cases. So the case will be reviewed and it will be directed to the clinical case coordinators. The clinical case coordinators is also a team of doctors that we have in MSF. They will be able to review the case and they'll be able to assign it directly to the specialist. So this is how basically how case management works. Okay. So even if the case is very urgent, the specialist will give his response within 24 hours, no matter the urgency of the case. So basically that is the case management and how it works. So let's say now the case management, now the specialist already reviewed and maybe the doctors still have questions to ask, they will go back to the platform and they will ask questions. So it's like a two-way conversation. Okay, it's not just by giving advice and that's the end of it. So in this case now, let's say the team of doctors now, they want to have a one-on-one conversation with the specialist. Now, this is where now we are going to go to the video case discussions, where now it's like the real-time video discussions where the field team can directly talk or have a conversation with the specialist and they can ask and explain about the patient and the condition, and they can ask the specialist all the questions they need about the management of the patient. Okay. Now, the secure messaging is more of a service that you're trying to get rid of WhatsApp, because WhatsApp, as we know, it's not confidential, and most of the stuff they exchange vital information through WhatsApp. So secure messaging is just which allows the healthcare professionals on the field just to communicate and share relevant files through which is more secure than WhatsApp. So secure messaging is just for the MSF staff just to exchange information between each other. And so this basically the three services. Yeah. So as Ivy said, just to add an addition to that, as Ivy said, we do not deal with the patient directly. It's provider to provider. Yeah.
All right.
Yeah.
Thank you very much. Ivy, I want to come to you, and even as you respond, we have two questions on the chat. I don't know which one you want to take as you respond on the issue about evolution, but we have Rolex Omondi, who is asking for statistics on the number of telemedicine cases that we have responded to in Kenya and across the region, and the nature of the cases. If this is something that you have, you can share. But if we don't have them right now, we can get in touch and supply Rolex with that data. Then there is John Muley also in the chat, and the question he asks is, of course, he has been engaged in a number of things, and he says he's really interested in telemedicine, and he asks, how has telemedicine helped in the management and treatment of cancer patients in Africa? He would want to know specifically about cancer in Africa. So those two questions: statistics on cases and their nature in Kenya and the region, and cancer management. Ivy?
Yes. So I don't know, should I start with a question on the future of telemedicine or go straight to the questions you have on the Q&A?
Okay, let's talk about the evolution and the future, then we can come to the questions. So that,
all right, so I'll do Q&A at the very end. Yeah, okay.
Right.
No problem. All right, so when it comes to the future of telemedicine, as we know, as in every organization, you all have a strategic plan, you all have, a framework that you're working towards. For telemedicine, remember you're hosted by MSF Canada. So with MSF Canada right now, it's all about transformative impact, and how that looks like for, at least for me in this position, or for the whole telemedicine program, is I am looking at not just being easily accessible and having all these tools and all these services being provided to projects and ultimately helping with quality patient care, but also as we evolve, what kind of services are we offering, and are they realistic? Are they easily accessible? Do they match what is actually needed from the field? And so how telemedicine is evolving within MSF, I would say, is through the constant feedback that you receive. I do think that because of how the telemedicine program works, we as the RIOs, which is the regional implementation officers, we are at the strategic point whereby we deal with the projects, and also we have this other avenue where we also deal now with the MSF Canada team. And so we are able to relay that feedback directly to them. So we are sort of like the go-between. So from the field, we get what is actually needed. And so that's where we are able to easily either adding certain features to some of the applications we have. Maybe like now, recently we had the voice notes one for secure messaging because we were told we need voice notes. Another one was the mobile application that is now using the case management service can now be accessed using a mobile application as well. And why? Because we realized that when though it was before, doctors had to set aside time to go and fill in the case on their laptop while they're doing their rounds, which was a bit tedious. And so the hope is with the mobile application, when they're doing their rounds in the hospitals, they can easily fill in the case at the bedside of the patient. Or if it is when it comes to like Cello, they can easily share the files in a secure manner, things like that. There's also the offline functionality that is the mobile app. As you know, many of the projects MSF operates in, they're in areas where internet connectivity is a bit of an issue. And so we are hoping with adding certain features such as those, we are not only keeping in touch with the evolution and, being what can I use? Being actually needed in the field and adapting slowly, but also that way showing the transformative impact that we have. So yeah, so that's how I would say we are evolving within MSF. Yeah.
Okay, thank you. Do you want to respond to any of the questions?
Yes, I will be adding in some data in the field, in the chat on the statistics on Kenya, because I do have that data. I'm hoping I'll be able to do that before the chat ends. In terms of the cancer treatment, I will not go into the details of it, but I'm pretty sure that we have also had some cases that are there. And if you need me to like fully delve into that, just write to me and I will respond to you and we can have a discussion on it. Yeah.
Thank you very much. Daniel, because you spoke about the challenges, I want you to respond to your namesake, Daniel, on the chat, who has raised a question on the 24-hour, turnaround time, like you have said. And his question is, how does this work in an emergency setup? There's an emergency, a medical need that is an emergency. Are they going to wait 24 hours, or is this one of the challenges we have where we say, no, this is not possible? How does that?
Okay. As a medical personnel myself, you see, like when you talk about emergency, when we are dealing with an emergency, even if it's in a remote setting, we have to deal with this situation at that time. So when I said within 24 hours, this is case management. Case management is a conversation between the treating doctor and the specialist. So it is not, when I say it's not an emergency, it does not really mean per se it's not an emergency. The treating doctor will post the case, which now will go to the specialist. So the specialist will have to review the case, ask all the questions that he needs to give. It's like more of a second opinion. That is why I said it takes 20. There is the specialist will respond back within 24 hours. It's more of a second opinion. Now, when it comes like to the VCD now, the video case discussions. Now, this is where in case, for example, the person who asked about the cancer treatment, for example, this is where you will find the team of doctors will come together and they will discuss with the patient in real time. Okay, so basically, as we say, telemedicine is still evolving. We're still trying to get there, where we can be able even to handle emergencies when they happen. But at the moment, so far, what we are doing is for case management, the response will get within 24 hours. For VCD, is when you're having discussions one-on-one with the specialists and the team of doctors on the ground. And the secure messaging, as you said, is more of an app we're trying to replace WhatsApp. So we cannot say at the moment that we are dealing with emergencies directly through case management. Yeah, but we are evolving, and with time, we are going to get there.
All right. Thank you very much. Daniel, another question for you, and I know Ivy has spoken about this. The two of you are the regional implementation officers, and you clearly cover a big geographical area. And as it has come out, it is the two of you who are able to probably, assess how this is working and maybe suggest improvements. I am sure you have seen, you have been to areas and you have noticed something and said, this is an improvement, or this is maybe an opportunity that we need to take advantage of. Are there untapped opportunities that you have noted that you think maybe not tapped in Kenya, but is working somewhere else that, can be improved? Or is it, watertight? Everything that is available is used. So the question is, are there untapped opportunities that you have noted? And are there ways that MSF teams can make, better use of telemedicine services?
So yeah, thank you for that question, John. So yeah, telemedicine, as we've all said, that it's growing and it's evolving on a day-to-day basis. So basically, like I can speak for my region, there's a lot of potential for telemedicine to grow. But as I've said, the challenges are still there, and we are trying on a day-to-day basis just to fight the challenges so that all the teams can be able to take up telemedicine. Okay. So another thing is in my region, what I've noticed is people are really receptive. They're taking the telemedicine very well. They're willing to learn. They're willing to train. They're willing to be trained to be able to understand what telemedicine is. But most of the time, also we get that not everybody will perceive telemedicine as a way of assistance or a way of they can be able to seek assistance from the specialist. Okay. So basically what I can say is, yeah, in my region, we have a lot of potential for telemedicine to grow. We are pushing every day. MSF, as you know, there are projects popping up every day. In my region, for example, in Congo, there are projects popping up every now and then. Now we have projects like in Ebola. Now where we have already created through secure messaging and in an Ebola intersectional group where now the doctors, anything that we, or rather, if we hear of an Ebola case, all the doctors they can be able to just to collect the data through the secure messaging. Okay, so in my region, I can say, yeah, there's a potential of growth in telemedicine in my region. I don't know if Ivy can be able to add onto that. But for me, basically, that is it.
Well, that's fine. Thank you. Ivy, anything to add?
I would say he's pretty much covered the essence of it. The opportunities are there. However, maybe one thing I would say is we can only grow as much as the support we receive from the MSF entities within, because remember, for us, we work intersectionally. Yes, we are a program that we run independently, hosted by MSF Canada. However, in the project, I would call upon the MSF entities to invest. So things like the technology aspect, because like, for example, as Daniel has mentioned in his region, most of the issues are with the tech access. So if a project does not have good internet connectivity, then they will not be able to access telemedicine or use the services as they should. So working together and being able to invest a lot more, I think will expand how telemedicine is taken in the field. Yeah.
Thank you. We are almost coming to the end. We have just about 10 or so minutes to close this discussion. Been very, insightful with a lot of information to learn. I see two questions on the chat. One is from Abdi Kadir, who is he's saying he has downloaded. Let me just read it verbatim. I have downloaded the telemedicine mobile app. However, it is not working for me. Could you please advise me on how to resolve this issue? If you have something to say, the question is directed to Ivy. If you have something to say about this, I know probably if we are physically sitting, you'd say, bring your gadget and you show how it works. If there is any advice you can give to that. And then Yolisa is asking if telemedicine services go beyond the health facilities, like providing continuum of care at the community level. I don't know who wants to take that. So Ivy, you take the app, and then Daniel will take Yolisa's question.
Yeah, sure. So yes, for the app, I can assist with that. Maybe I could type my email in my email address so that you can reach out to me directly. I'm afraid this is something now that goes not to the technical side, but yes, I can be able to assist you. No problem.
Thank you.
Yeah.
All right, thank you.
Daniel. Oh, there's also the question on Kenya. I have the statistics. So in Kenya, so far since 2021, we've had about 500 or so cases posted, 516 cases posted. And in Kenya, we have the biggest project I would say in Kenya that posts cases is either the Dadaab Dagahali project, or the Homa Bay one that we have as well. So a lot of radiology cases, infectious disease cases are what we see mostly on our platform. Yeah.
Okay, Rolex, I hope you got that. Just in case you probably need something further, I know you will get in touch and we can then speak to Ivy. Daniel, you want to respond to
Yeah,
Yolisa?
yeah. So, Yolisa, basically for telemedicine, we work with the MSF projects that are on the community level, and usually it is mostly this medical staff providing care to the community. That's where now we are pushing the telemedicine to the ground level, where the medical team can be able to access telemedicine. So just in summary, telemedicine is there for every MSF staff. They can be able to use it freely. They can be able to post cases as much as they want. And telemedicine is there just to assist each and every medical staff to be able to make better clinical decisions when they're taking care of patients on the ground. Yeah.
Thank you. There's an interesting question from Arab. I will just read it, okay? And then Ivy or Daniel, you will decide who responds. So he asks, telemedicine is very efficient in remote areas where there is no access to specialized care from a point of experience perspective. I would like MSF to maximize its expansion through the use of, okay, I think the question moved, yes. The one I wanted to ask, sorry, was from Daniel. I saw Daniel, and then I think the other one came in and my slide moved. So Daniel is asking, what Arop is saying is an encouragement to MSF that he has seen how efficient this is and hoping that we are able to do even more. But Daniel is asking the question I wanted to bring about on misdiagnosis, that how can telemedicine ensure accurate diagnosis when physical examination is limited or completely unavailable, and who bears responsibility when a misdiagnosis occurs? Have you had cases of misdiagnosis? I think that is the question. And what happens in such a case?
So basically, I can go on this. Telemedicine, when, as I said, the specialist is not responsible for the patient. The treating doctors on the team, they are responsible for the patient. The specialist only gives his second opinion. Now, the team on the ground will use this second opinion. It's either they use it or not use it, because they know the resources on the ground. Because most of the projects in the fields, they have limited resources. So as I said, telemedicine is not there to replace the medical staff in the projects. It is just there to assist with better clinical decision making. The specialist is not there, or is not there just to, or rather, the telemedicine is not to replace. Telemedicine is not there to replace. How can I say this? Telemedicine is there, but is not there to replace the doctors on the ground. I don't know if I'm making myself clear. So it complements. Well, that's the correct word I was looking for. So the team on the ground, they are responsible for the patient, not the specialists. Okay. So
I would like to add to what Daniel. I would like to add to what Daniel has said. Also, when it comes to, I'm assuming this is referring to the case management service that we have. When it comes to how even the cases are allocated, before the specialist even responds, the whole idea is that the telemedicine platform has been developed with the user in mind. This means the project staff in mind, which means that when they are posting their case, we encourage them as much as possible to write or to describe the state of the patient and describe the case to the fullest extent. And then they can also upload attachments. They do all these things. So before it gets to the specialists, also remember the clinical case coordinators are doctors themselves. And so they'll be able to look at all that evidence that has been provided in the platform to provide accurate responses. So have we ever had a case of misdiagnosis? I haven't had any yet. However, if you're interested in, if you really want to learn more about telemedicine, I'm seeing the team has also shared the website and everything, and you can always reach out to us. We have all these metrics on our back end. Again, this was just an initial webinar just to advertise what telemedicine is all about. And so, yeah, so I'm not saying that, I don't think we've had any misdiagnoses yet, but if we've had, I'm sure there are also lessons that we learned from that. And the way the system has been set up is to be able to avoid any of that happening. Yeah.
Okay, thank you very much. Thank you, ladies and gentlemen. We have 5 minutes to get to the top of the hour. There's a question. I know Ivy, you spoke about this earlier on, but Wangui, for the benefit of hearing it from you, if there have been any cases of resistance, I think from the community or patients or something like that. Although I know you have said the connection between the specialist and the community is very limited, or almost zero. But maybe they know that there is this service technology that is being used to offer services to them. Have you had any cases?
Not directly from the community, but of course, as you know, with MSF, we work with also national doctors. And I wouldn't really call it resistance. I would say it's the initial, in every adoption of anything, there's the early ones who want, the early adopters, and then the late ones, and also the ones who are a bit skeptical. It happens in every setting. And so there has been instances where maybe the national doctors are maybe a bit, I wouldn't say afraid, skeptical of using the services, but once you do the trainings, you do the support, and they actually show them case studies of where it has worked, even for projects that are sort of similar to where they are. We've seen that resistance or skepticism erode. And so for now, I would say not yet to the community. We have not had any resistance per se. And most of the skepticism we see from national staff eventually turns into them actually even being champions for telemedicine and using it. So, so far, I think the reception is good with, of course, when we consistently train them and consistently support them, we do see that increase in usage. Yeah.
Well, thank you very much. We have basically come to the end of this webinar. I will allow Daniel 30 seconds to give his final remark, anything that you have left behind. Someone is asking about AI in telemedicine, and then Ivy, someone may be asking, because MSF is a donor-funded organization, how can they help support this program, and things like that. And then when Ivy is done, the technical team here has a nice video for all of us to watch. And after the video, we will all be free to leave. So very fast, we have 2 minutes to go. Daniel, one last word, and then Ivy.
So I've seen in the chat people from Chad have already have joined. So I've seen some of them from Abutenge. So just to mention, I'll be coming to Chad in October to do a field visit. I'm going to come there. We're going to have a one-on-one with the teams, conduct a workshop, visit some of the projects, try to expound more on telemedicine, and I hope to see most of the projects and medical staff there. And if there's any question about telemedicine, especially in the Central African region, do not hesitate to write to me. I'm here to assist you and to help you understand better on our services. Thank you very much, everyone who attended, and you can always keep in touch. Yeah.
Sure, thank you. Ivy.
Yeah, to close off, I think my final message is 2 ways. One is internally to MSF staff who are on this webinar. Telemedicine can only serve as much as you're willing to invest in the projects that we manage. So if you have a project that you oversee or things like that, and you see that telemedicine is useful there, or it has not yet been tapped as much as you can, reach out to any of us, Daniel or myself, or even the telemedicine team. Will be able to support you in that. The second one is to everybody else here. If you're a volunteer, we're always looking for volunteer specialists. So if you're a specialist, you can always volunteer to our network, and we have the links up on our website. So you can visit our website. You can follow us on social media or follow the MSF page on social media. I'm sure somebody will assist you to get to us. You can also follow our website. And yes, I believe there's a lot of potential for telemedicine to expand, and looking forward to seeing that happen. Hopefully the next webinar will be, oh my God, we expanded so much. And that will be amazing.
Sure, yes. You something about AI? Please, someone has sneaked in a question.
AI, not yet for now. However, it is a conversation that is still evolving.
Like everywhere else.
Like
Okay.
everywhere else.
Thank you very much, ladies and gentlemen. Thank you, Ivy and Daniel, for sharing these insights with us this morning. And thank you, everyone else who has attended. Please stay in touch. If you cannot reach Ivy and Daniel, they can share their addresses, or you can reach out to us directly. You can find us on our socials. Just reach out and say you're following up on this. If you know us, anyone of us who works in the communications team here at MSF Eastern Africa, please also feel free to reach out to us. Until some other time, the team here is ready to play the next video. And after that, everyone
MSF's telemedicine program helps healthcare professionals collaborate, share knowledge, and improve patient outcomes. We do this by connecting medical specialists from around the world. Let us show you how. Say in West Africa, a remote clinic needs specialized knowledge and skills in pediatric cardiology, but doesn't have the resources available. This clinic can post a patient's case to the telemedicine platform. We can connect the project team to a pediatric cardiologist. We can advise staff on how to best treat the patient. Let's say in South Asia, a project is experiencing an influx of patients with advanced HIV. By hosting weekly discussions in real time, we can connect the project team to an infectious disease specialist. Together, they can collaborate to learn, discuss, and help diagnose future complex cases. Or let's say a team in the Middle East is referring a patient to an MSF hospital. By using our secure messaging service, staff can instantly and securely discuss patient care and transfer details. These examples are showing only some of the ways our services could be used. As a program, we aim to connect a global network of specialists to empower MSF staff and reduce their isolation. We aim to foster a global community of knowledge and ultimately contribute to better outcomes for our patients. To learn more, visit us at telemedhub.org.
Goodbye, everyone. See you next time.
Thank you. Goodbye.